many think because they'll not be knowing what is anesthesia. And, you also must have, you can remember your days, the early days when you joined, probably did not know anything about anesthesia. And many times what happens is, MBBS course, we hardly gave importance during our surgery postings towards what is happening at the head end, isn't it? And even when you are posted to anesthesia, you will not be in anesthesia as such. You will be more interested in looking at what surgery is being done, how it's being done. So many of us actually will not know much about the anesthesia. I don't know about the nowadays, you people, the present generation of students. How about you? You knew much about anesthesia when you joined anesthesia, or you did not know much about anesthesia?
So they did
After joining, sir.
Only after joining, that is what. Because I was trying to tell you about my experience as a first year postgraduate. That is nearly 40 years back. I think the same thing is now also holds good, isn't it? So I think that course would help many of the students to have some knowledge about different, parts of anesthesia, like general anesthesia, regional anesthesia, and how it is done. Because, I took airway, actually assessment of the airway and different airway gadgets. So my lecture was on that. And, other people also did, inhalation anesthetics, many of that, the pharmacology of IV anesthetic agents. So all basic, subjects of anesthesia were introduced to the young students. If they are there today also, if they join, I think it definitely is going to help them regarding the local anesthetics. So the pharmacology of local anesthetics. Anyway, any doubts regarding our previous lectures? Anup and Nina, any doubts regarding anything just like that? Because, I always, ask few of the doubts or anything just before we start our definite, the subject of that particular day. So that, just to warm you up, so that you'll also relax before you start off. So any doubts regarding anything regarding the previous ones, regarding our case discussions, regarding the many of the intravenous anesthetic agents, we finished inhalation anesthetic agents, we completed. Any doubts there? Everything has been understood, is it? No doubts. That's what I was telling. Either you have understood the whole thing or you have understood nothing. In between, you will have doubts. If you have something in between, you will have doubts. Otherwise, there won't be any doubts. I hope you are in that extreme of you have understood everything. Okay, let's start off pharmacology of local anesthetics. I think you have got a lot of time to prepare yourself. I think you'll be able to discuss very actively with me, probably. And, always whenever you start off with anything, part of anesthesia, it's always the history is very, very important. A little bit about history of local anesthetics before actually going in for the pharmacology of the local anesthetics. Actually, you all know that initially it was all inhalation anesthetic agents only. When ether was introduced in 1846, and then chloroform, and then cyclopropane, for almost nearly 40 years, it was only inhalation anesthetic agents, because people were thinking that anesthesia means it is always general anesthesia and inhalation anesthetic agents. And people did not know anything about, they had not even heard about this, regional anesthesia, which actually now you all know that it is a major branch of anesthesia itself. So many of the surgeries will be doing under regional anesthesia rather than going in for general anesthesia. So it was not heard of. So actually, when these concept of regional anesthesia started, actually, which year and who introduced the first local anesthetic agent, or who gets the credit of introducing the first local anesthetic agent? Anup, can you just...
Cocaine. So cocaine was introduced in
Very good. Cocaine was the first local anesthetic agent that was introduced, and
18,
ah,
in
18,
1880s. Not sure the date.
1883.
Okay, sir.
1883, the first local anesthetic cocaine was used. Of course, nowadays we are not using cocaine for local anesthesia, at least in India. In US, they still use cocaine for nasal anesthesia. I'll come to that. So, who gets the credit of, or you can call the father of local anesthetics?
Uh, Halstead also used and Beer also used spinal
No, no, no,
anesthesia, sir.
no. No, that is different. Who introduced and who gets the credit of introducing cocaine for regional anesthesia? He was an ophthalmologist in
Okay,
Austria,
sir.
in Vienna, one of the hospitals, major hospitals in Vienna. Karl Koller.
Kohler, yes, sir. Kohler.
Karl Koller. You should always remember these names because, invariably, I keep telling you people, because when you're answering very well, they'll start asking about history because they know that you don't answer anything about history. And if you answer history part also, you'll get a lot of marks. So Karl Koller
Kohler.
can consider K-O-L-L-E-R.
Yeah.
K-A-R-L, Karl, K-O-L-L-E-R, Karl Koller. So he has been given the credit of introducing cocaine
Okay.
for as local anesthetic. And he was the first person to start regional anesthesia. I told you, he was an ophthalmologist. Now, what used to happen was he was an ophthalmologist and he was doing all eye surgeries using ether or chloroform. During those days, I told you, those were the anesthetic agents that were being used, and all patients were giving GA. And majority of these patients used to have postoperative nausea and vomiting because of these inhalation anesthetic agents. And invariably, it used to increase the intraocular pressures, and many of the surgeries used to be a failure. So actually, Koller was in search of some anesthetic which could act locally there so that he could put the anesthetic agent inside the eye and it could act there, and then he could perform some surgeries. So who gave him the idea of cocaine could be used as a local anesthetic?
That Halstead, sir.
No, no. Sigmund Freud.
Right, okay.
Halstead was a British or American, probably, I don't know, but he was nowhere there in the Vienna hospital. So Sigmund Freud was there as a psychiatrist there. Sigmund Freud is the father of psychiatry. You should remember, father of local anesthetics, you can say Karl Koller, and father of psychiatry was Sigmund Freud. So he was there. He was actually using cocaine for relieving patients from morphine addiction. So he was thinking that cocaine would relieve morphine addiction but nobody knew that cocaine could produce numbness. So one day when he was he started using himself also cocaine. He became a cocaine addict also, and then he licked it, and that that area of the tongue became numb. Then suddenly he realized that why can't it be used as a local anesthetic agent, because it is producing numbness locally. That's how he gave the idea to Karl Koller, his very close friend, an ophthalmologist there in the same hospital. Actually, later Sigmund Freud developed a malignancy of his soft palate. So he underwent a lot of surgeries. So he became a cocaine addict also. And finally, he undergoes euthanasia by getting injected with high dose of morphine, and he dies because of excruciating pain of malignancy. He's a very heavy smoker. That's how he develops a malignancy. That is just history, just for your interest, I was talking about. But Sigmund Freud name also you should always remember. You ask any psychiatry postgraduate, they'll be knowing about Sigmund Freud because father of psychiatry. So Sigmund Freud gave the idea of cocaine could be used as a local anesthetic agent to Karl Koller. So Koller, what he did was he diluted that powder of cocaine. Cocaine was being available as powder. Even I think cocaine is available as powder also. People, what they use it as a snuff also. So they inhale it to get a kick, of course. So cocaine was diluted, and then he places these cocaine drops into his own eyes. and he stands in front of a mirror and touches his cornea with a sharp pin, and he will not feel any pain. So he gets elated. He starts using cocaine as a local anesthetic on his patients for eye surgeries. So actually, there would be a nearby in another city, conference would be there, of ophthalmology conference. He wanted to present his paper. He did not have enough money to go there and attend the conference. So he gives all his papers to one of his friends to present it. The cocaine being used as a local anesthetics agent. So because probably the doctors were very poor, were less paid during those days. I don't know about present days. So anyway, that's how cocaine became the first local anesthetic agent introduced, and Karl Koller gets the credit of introducing cocaine for regional anesthesia as a local anesthetic agent. So who actually gives cocaine or introduces cocaine intrathecally, though not for spinal anesthesia? Who gave first? These are all, everything is there in history. If you just
Beer.
who
Beer.
no. Bayer used it as for spinal anesthesia.
Okay.
Intrathecal introduction of cocaine was by William Corning, who was a physician. William Corning was a physician. So he thought that patients who are paralyzed, paraplegic, could be treated with giving intrathecal cocaine. But of course, it will not help. So that's how he thought that it could be used intrathecally. That is, the concept of intrathecal use of local anesthetics was by William Corning. But for spinal anesthesia, it was used by August Bayer. Which year? August Bayer.
Nine.
1883, cocaine was
Okay.
introduced. Which year cocaine was used for spinal anesthesia? It was used in 1898. This you should always remember, because today you are using spinal anesthesia, isn't it? So brief history about spinal anesthesia you should always know about, because cocaine was first used for intrathecal anesthesia. That was in 1898 by August Bayer, a German anesthesiologist. Of course, he was a surgeon actually. Those days, anesthesia, specifically anesthetists, were not there. So actually, he asked one of his assistants, Hildebrand, to give him spinal anesthesia using cocaine. So he introduced the needle, and then CSF started pouring. But when he tried to fit the syringe was not fitting the spinal needle. So, but he introduced cocaine, but most of it came out when Hildebrand tried to push cocaine into the Bayer's intrathecal space. Bayer did not get the effect. Then immediately what Bayer said was, no, I'll give the spinal anesthesia to you. So he made Hildebrand to lie down. But before that, he checked whether the spinal needle and the syringe fits properly or not. Then he gave, then it acted immediately. And actually, he hammers the shin of Hildebrand to see whether there is any pain. Hildebrand would be laughing, so he did not have any pain. So that's how the spinal anesthesia was born. Now every day, at least out of 10 patients, you'll be using 5 patients spinal anesthesia. It has become so popular, isn't it? So that's how spinal anesthesia was born. Actually, they wanted to celebrate on the next day of the spinal anesthesia, success. So, but both of them could not celebrate because of what? They were not able to get up. What was the reason?
Clock.
Cocaine is a very short-acting drug.
Okay.
It's just about 30, maximum 30 minutes. That's all. That is not the reason.
The level.
Developed PDPH, post-dural puncture headache. Both of them developed because, those days,
Needles.
fine needles, very large needles, maybe 18 gauge, 16 gauge spinal needles. reusable spinal needles. So that's how, both of them developed severe headache. So they celebrated it only after 10 days. So this is just about brief history. And, later procaine was introduced in 1903 and chloroprocaine was introduced in 1930s. And in 1943, lidocaine was introduced. It was a revolutionary introduction because it was the first amide local anesthetic that was introduced.
Yes.
1943. So who introduced lidocaine?
After
Lofgren and two people, Lofgren and Lundquist.
okay.
Lofgren and Lundquist
Lund-
introduced lidocaine. That was in 1943.
1943.
And which year bupivacaine was introduced? The long-acting.
1963.
Yeah, very good. 1963. Who introduced? Icenstam. Icenstam was the person who just remember about these names. Now, because of our discussion, I think you'll remember it even during your exams. You'll not forget these things. Icenstam was the person who introduced bupivacaine for regional anesthesia. Then when was the ropivacaine introduced? Because these are the local anesthetics which we are using.
2000 was levobupropion.
No, both of them were introduced in 1990s. 1993, ropivacaine was introduced. 1997 to 1999, that time, levobupropion was introduced. So after that, no newer local anesthetics have been introduced, at least not available in India. Of course, liposomal bupivacaine, all those things are different, but they're the same preparations with slight modifications, that's all. So this is about the brief history of local anesthetics. And what is the basic structure of a local anesthetic agent?
There's one aromatic group.
Yeah, very good.
Group, and it is connected by interlinked carbon groups.
Very good. So an aromatic group and an amine group. This aromatic group is what? It is hydrophilic or hydrophobic?
Hydrophilic.
Aromatic group. Benzene ring.
Is lipophilic, which is hydrophobic.
That is what we always, sometimes instead of telling lipophilic, we say hydrophilic and hydrophobic. Hydrophobic is lipophilic.
Okay.
That aromatic group actually gives the lipophilicity of the local anesthetic. And the amine group is the hydrophilic one. So it has got an aromatic group and an amine group and a link in between. Suppose if this link is replaced by an ester. Ester is COO. If intermediate link has got a COO, that is an ester, it becomes an ester local anesthetic agent. And this intermediate link is replaced by an amide, NHCO. Amide is NHCO. So that becomes an amide local anesthetic. So you have an ester local anesthetic agent and amide local anesthetic agent by replacing an ester or an amide of that intermediate chain or the intermediate link. How do you, by their name of these local anesthetics, how do you know it is an ester or an amide?
You have a single eye. It is
very good.
Ester.
Two eyes.
Single eye will be there in
Ester group.
Procaine.
Ester. Yeah, ester you have a
single
eye. And in case of amide, there will be a two eyes.
Two eyes.
Okay, so that's how. Otherwise, how do you classify the local anesthetic agents? So one is as for the structure. Just now we discussed either it can be an amide local anesthetic agent or a ester local anesthetic agent based on the structure. So can you give examples for ester local anesthetic agents?
Ester, you have chlorprocaine,
Procaine.
Cocaine. You can start with cocaine, isn't it? The first local anesthetic.
Cocaine.
Cocaine.
Procaine.
Procaine.
Chloroprocaine.
Chloroprocaine.
Tetracaine.
Tetracaine, or otherwise also called as amithocaine. So these are the ester local anesthetic agents? Or can you give examples for amide local anesthetic agents?
Amide, you have
Lignocaine,
lignocaine,
mepivacaine,
Lidocaine. Don't say
bupivacaine,
lignocaine. Lignocaine name is gone.
lidocaine.
This generic name of this is lidocaine. And
Lidocaine.
even in the exam, don't tell about xylocaine. Xylocaine is a trade name. It is not the generic pharmacological name. Now the pharmacological name is lidocaine.
Lidocaine.
Okay, lidocaine, then
Lidocaine,
mepivacaine, bupivacaine,
mepivacaine,
bupivacaine,
propivacaine,
levobupivacaine,
levobupivacaine, etidocaine.
etidocaine.
These are all amide local anesthetic agents. So this is one way of classifying the local anesthetic agent. What is the second method of classification? Based on their potency and classification.
Potency.
Yeah. Can you just tell which are the least potent, the intermediate potency, and then highly potent, least potent group of drugs?
Least potent, bupi short acting. No?
Least potent. Others are least potent except tetracaine.
Okay.
Tetracaine is an ester, but it is a highly potent local anesthetic. Otherwise, all your cocaine, procaine, chloroprocaine, all are least potent. Can you give examples of intermediate potency of local anesthetic agents?
Intermediate lignocaine.
Lidocaine 1,
Lidocaine.
then mepivacaine, prilocaine.
Lidocaine.
These things you can remember.
Intermediate.
Mepivacaine, prilocaine, they are having intermediate potency.
Intermediate.
Then highly potent are
bupivacaine,
yeah, levobupivacaine, then etidocaine, tetracaine.
tetracaine.
Yeah, only tetracaine here is an ester. Otherwise, all these are amino amides. Okay. Then you have another way of classification is depending on their duration of action. Which has got the least duration of action or very short acting.
Shortest acting is
Chloroprocaine.
All esters, same thing. Just now, what we discussed about their potency. So all esters which are least potent also have got the shortest duration.
acting. Yes.
Like cocaine, procaine, chloroprocaine. All three are short duration.
Acting.
Then intermediate duration,
Lidocaine,
lidocaine, mepivacaine, and prilocaine. Same thing as their potency and duration of action, almost same. And then highly potent or have a long duration.
Long duration of action.
So that's how you classify these. Next, where do these local anesthetic act actually on the axon? Where do they act? Which part of the axon they'll be acting, or the nerve fiber?
Inside axoplasm, in the sodium channel. Cytoplasm.
They act on the voltage-gated
Sodium channels.
voltage-gated sodium channels. Where are these voltage-gated sodium channels present for the nerve fiber?
Axoplasm.
Pardon?
Axoplasm, sir. Just below.
No, that will be present over the nerve fiber itself, isn't it?
Okay.
They enter into the exoplasm also because externally they have the opening and they enter into the intracellular area also, these sodium channels. So where they are concentrated actually, because you have two types of fibers, the myelinated fibers and unmyelinated fibers, isn't it? So in myelinated fibers, where they are concentrated, in non-myelinated fibers, where they are concentrated. That is what you have to know also, because sometimes mechanism of action of local anesthetics is 10 marks question, short notes. Many times it has been asked, mechanism of action of local anesthetics. So for that, you have to know these sodium channels, where they are present. Actually, in myelinated fibers, you have nodes of Ranvier.
Okay.
What are these nodes of Ranvier as far as the myelinated fibers are concerned?
Where the conduction takes place.
No, which part of the myelinated fibers you call it as nodes of Ranvier?
The space between each myelin. It's
where there is a differentiated myelin sheath. there is intermittently there is deficiency of myelin sheath, isn't it? And where there is a deficiency of myelin sheath, that particular part is called as node of Ranvier or Ranvier. So at that nodes of Ranvier, highly concentrated sodium channels. Sodium channels are highly concentrated there. Maximum number of sodium channels will be there as far as myelinated fibers are concerned. Whereas the non-myelinated fibers, where they are?
Throughout the
Throughout the
nerves.
Yeah, throughout over the axon.
axons.
They are present all over the axon. Continuously they are present, sodium channels. So what is the implication of this particular knowledge of sodium channels only concentrated at nodes of Ranvier in myelinated fibers, whereas all along the nerve fiber in case of non-myelinated fibers?
The action, how it acts, how it penetrates through the layers. So in the nodes of Ranvier, it enters the central part very quickly from outside to in.
The nerve conduction occurs. An impulse, how does it gets conducted? In case of myelinated fibers and in non-myelinated fibers, where the depolarization will be occurring in myelinated fibers and non-myelinated fibers.
Synaptic clefts.
It will be occurring at the nodes of Ranvier.
Okay.
So action potential jumps from one node of Ranvier to
another one.
So it's very fast conduction. The conduction is very fast with myelinated fibers, whereas with non-myelinated fibers, it has to go all along the nerve fiber. The depolarization, the action potential has to be conducted, or impulse or action potential. So it takes a longer time. So the conduction is quite slow in case of non-myelinated fibers, whereas conduction is very fast in myelinated fibers.
Right.
And how about the effect of local anesthetics on these myelinated fibers and non-myelinated fibers? How does it act on myelinated fibers? And this conduction in case of myelinated fibers, where it starts jumping from one node to another node, is called as saltatory conduction. All these things you must have read in your physiology. Saltatory conduction. So that's how the conduction is quite rapid in case of myelinated fibers. So naturally, sodium channels, voltage-gated sodium channels, when they are there at the nodes of Ranvier, so your local anesthetics will be acting there only in myelinated fibers. Whereas in non-myelinated fibers, they have to act all along the nerve fibers, isn't it? So how many nodes of Ranvier have to be blocked to block the conduction of the impulse through a myelinated fiber? How many nodes of Ranvier have to be blocked by the local anesthetic to block the conduction?
3 to 4.
At least 2 to 3. If 2 to 3 nodes of Ranvier, where voltage-gated sodium channels are there, they can get blocked. So naturally, the conduction will get blocked. So naturally, anesthesia, beyond that, there will be anesthesia. Whereas for myelinated fibers, a particular length of the nerve fibers where sodium channels are concentrated all along have to be blocked. So because of this knowledge, so local anesthetics can block a myelinated fibers better or non-myelinated fiber better?
Myelinated. So it jumps off.
Pardon?
Myelinated?
Yeah, myelinated fibers are very sensitive to local anesthetic act. Non-myelinated fibers are very resistant to local anesthetic effect. They're highly resistant. So that is what is very, very important. So for that, you have to know the different or classification of these nerve fibers. How the nerve fibers are classified actually. Basically, I've told you myelinated, non-myelinated. So what are these myelinated nerve fibers? How they are classified?
A, B, and C.
Conducting, fast acting, A delta, A beta. Then C.
No, you should tell properly, isn't it? A fibers, B fibers, C fibers. Yes. Now you know. A and B fibers are myelinated, C fibers are non-myelinated. A and B, and again A fibers are subclassified into
A
A
alpha,
alpha,
beta,
beta, and delta.
deltas.
yeah, A alpha, A beta, A gamma, and A delta.
Delta.
4 subsets are there. A alpha, A beta, A gamma, and A
Gamma
delta.
and delta.
And you have B and C fibers. So based on their thickness and conduction velocity. A alpha fibers are myelinated. They are very thick fibers. They are very fast conducting. So what this thing they'll become what kind of sensation or
Sensory.
Yeah.
Progress. Sensory.
Sensory and basically A alpha
Pressure touch.
they are basically
Proprioception and touch pressure, sir.
Yeah, basically motor. A alpha. A beta is your proprioception and touch. Touch and pressure and proprioception is A beta. A alpha is motor fibers. And A gamma is, what are these fibers? A gamma
A
fibers.
delta is fast pain,
Temperature.
sir. Pain.
No, A gamma you just tell, don't go into A delta.
Temperature.
A gamma is actually the fiber supplying the muscle spindles.
Yes, sir. Muscle spindle.
Yeah, they are the afferents of the muscle spindles. Efferents and afferents are A gamma. And A delta, as you are telling,
The fast pain conduction.
they are fine pain fine pain
Pain conduction.
sensation they carry. The afferents, fine pain, like the cutaneous
Much pain pick.
or somatic pain. You can easily recognize exactly from where you are having that pain, like pinprick.
Pinprick, yes.
By A delta fibers. Plus, what temperature also is carried by these fibers. Which particular temperature sensation? Is
Cold.
it cold or warm?
Cold.
Cold sensation is also by
A delta.
Okay. Now, what are these B fibers?
Unmyelinated.
No. B fibers are myelinated.
Myelinated.
C fibers. Both A delta and B fibers are of the same thickness and same conduction velocity, almost similar. And B fibers are, what are these B fibers actually? What they conduct?
Preganglion.
Very good. Preganglionic efferents. Sympathetic efferents. Preganglionic sympathetic. From the spinal cord to the sympathetic ganglia of B fibers. And then what are the C fibers?
Unmyelinated pain.
Unmyelinated, what they carry?
That was a pain only, but
motor.
Pain of what? Which pain?
Slow.
Visceral pain.
Visceral pain.
Yeah, visceral pain is carried by C fibers.
C fibers.
And also, the temperature, especially the warmth sensation, is carried by C fibers.
C fibers.
So the visceral pain and also ischemic pain, for example, tourniquet pain, is again carried by C fibers. And the warmth temperature sensation is also carried by C fibers.
C fibers.
So among them, when you give, for example, let's say you give spinal anesthesia. So which fibers get blocked first and which fibers get the later in a sequence? Can you just tell the sequence of fibers getting blocked when you give local anesthetic into an intrathecal space, that is a spinal anesthesia?
Sensation will be lost.
First will be which fiber gets blocked?
A delta, sir.
It is B fibers.
B
fibers which get blocked. So B fibers are sympathetic efferents, preganglionic fibers. So immediately, there won't be any impulse generation beyond the ganglion. So what will happen now? Once the B fibers are blocked first.
Then cold.
No, what will happen? B fibers are basically, I told you, preganglionic efferents. So what are these sympathetic fibers? What they produce actually?
Hypertension.
Pardon? What they produce? Vasoconstriction, isn't it? Stimulation.
Hypertension.
Now, blocking of these B fibers produce vasodilatation. immediately there will be a peripheral vasodilatation, especially the venodilatation, and the patient can develop hypotension. Hypotension can be very rapid because the B fibers are the first one to get blocked when you give spinal anesthesia. And after that is A delta. Immediately, almost, because both are of the same thickness and same conduction velocity, B fibers, and immediately A delta fibers get blocked. So A delta fibers getting blocked means what sensation is blocked?
Cold sensation and fine
prick.
Fine pain and cold sensations are lost. So analgesia will be there immediately. Somatic analgesia. If you just prick the patient, the skin, the patient will not feel the pain at that point where it is blocked. Plus, the patient, the cold sensation is not being conducted at all. So what is the other sensation, what the patient feels?
tingling.
The warmth.
Warmth he can feel.
Because he is not feeling cold. Naturally, the unopposed, because the C fibers are not blocked yet. I told you they are resistant because they are non-myelinated. Though they are thinnest fibers, but they don't get blocked because of they are non-myelinated. They are resistant for local anesthetic block. So the patient will feel warm. That is what probably you will be asking as soon as you give spinal anesthesia and turn the patient. You'll be asking, are you feeling warmth or not? Isn't it? That is the first sensation the patient will have, so that you will be satisfied whether your local anesthesia case acted or not. Because after giving spinal anesthesia, the anesthesia that always will be there in your back of your mind, whether it has acted, whether I have given correctly or not. So immediately you'll ask the patient whether he is feeling warmth. And he'll be feeling warmth because of the blockade of A delta fibers. Because cold sensation is being carried by A delta fibers, they are getting blocked. Unopposed warm sensation, immediately the patient will have. It is not because of vasodilatation, mind you. It is because of the C fibers carrying warm sensation the patient will have. What is the next fiber which get blocked in a sequence?
A alpha.
A gamma.
A
gamma, and then A beta. And then after that, among the myelinated, A alpha will be getting blocked last because it is thickest nerve fiber, A delta. So you have first B fibers, then A delta, and then A gamma, A beta, and
last
then
A alpha.
A alpha will be the last. So motor blockade starts later because A alpha. First touch sensation is last, proprioception and touch, and afterwards is the motor blockade. So you must have done your dissertations on spinal anesthesia, onset of motor blockade, onset of sensory block. Onset of motor blockade will always be slightly later than onset of sensory block. And that is mainly because of how these local anesthetics can act. And then the last one to get blocked, if at all, if it gets blocked, is C fibers. They are highly resistant to the action of local anesthetics. That is one thing you always realize. Why should you know that they are highly resistant to local anesthetic effect? The C fibers, which carry the visceral sensation. What is the application of this particular idea or the knowledge?
Stretching of the organs in abdomen surgeries.
Very good. So, the pulling of the organs by the anesthesia, by the surgeon, can still be felt by the, because the vague sensation of sickening feeling of this can be felt by the patient. Plus tourniquet pain. Many times after giving spinal anesthesia, still when they apply tourniquet, sometimes the patient may still feel the pain because that is pain is being carried by C fibers. C fibers are highly resistant for local anesthetic action. They are very, very sensitive to a particular group of drugs. Which group of drugs? They are highly sensitive, C fibers. Opiates. Opiates are very effective in blocking the sensation of C fibers. Now, this knowledge is very important when you combine an opiate with a local anesthetic agent. You need not have to worry about C fibers because opiates will take care of the C fibers. And all myelinated fibers, the local anesthetics will take care. That's how, in labor analgesia. So initially when labor analgesia was introduced, so high concentration of bupivacaine had to be used. Almost they were using 0.5% bupivacaine. And you know that invariably 0.5% bupivacaine intrathecally or epidurally will produce total motor blockade. And that's how the incidence of cesarean section was very high. Later, they started using 0.25. Even 0.25% of bupivacaine will produce motor blockade. So then they realized about this particular knowledge about C fibers being blocked by, opioids, because almost the entire first stage is by the C fibers. First stage where the uterus is contracting, and that pain is carried by C fibers only. And later also, though the somatic pain of that second stage will be very severe, but still that visceral pain also will continue. So that's how, when they combined opioids with local anesthetics like, fentanyl with bupivacaine, so they could reduce the concentration of bupivacaine from 0.25 to 0.125 to 0.0625% to 0.05%. Now we hardly use. So it's only the analgesia, and that is for somatic use local anesthetic, for visceral use opioids. So that is how this knowledge is very, very important regarding the local anesthetics and their effect on different kinds of fibers, nerve fibers. How will be the recovery? Which fibers recover first from local anesthetics?
The same opposite order.
Reverse order.
Very good, very good. The same opposite order. The C fibers, though they are the smallest fibers, thinnest fibers, they recover rapidly first. And then, you have the B fibers, and then A delta, and sorry, not the reverse. Sorry. The C fibers first, and then A alpha fibers. A alpha fibers, then A beta, A gamma, A delta, and B fibers are the last one to, they are the first one to have it, and they are the last one to recover. Knowledge is important again. The B fibers, they recover the late or the last. Why should you know about this as anesthesiologist?
If the patient is moving their legs, a sensory blockade might be still present.
Motor blockade already gone.
Yes.
Then
But sensory-
pain also, the patient will be feeling the pain at the site of surgery, but still the patient can have B fibers blocked. Can still there be quite a bit of sympathetic block, and this can produce, when you move the patient, there can be severe fall of blood pressure. Because B fibers are the last one to recover, and the patient is, has got a labile hemodynamic status. So you have to be very careful when you move the patient from, think, okay, everything is fine, patient is moving his limbs and patient is also having some pain. So the surgery is over, I'm going to move the patient from intraoperative site, that is from the OT to the postoperative ward. That during when you shift, always there is a possibility of severe fall of blood pressure. And I've seen patients entering into the postoperative ward almost nearly in a collapse state. And even some patients have died. That's why, this knowledge is very important, because the B fibers are last one to recover. Still the patient has got a labile hemodynamic status, and you have to continuously monitor the patient. You have to go with the patient. You have to immediately check the blood pressure in the postoperative ward, and you have to carry vasopressors with you. Or many times what I would advise is you just give a 3 milligram dose of amphetamine or ephedrine before shifting, so that you don't have to worry at all for the fall of blood pressure on the way. So that is why, we should know about these things. So knowledge about the nerve fibers and the effect of local anesthetics on these nerve fibers becomes very important. Okay, now we know that these local anesthetics will act on the voltage-gated sodium channel on the nodes of Ranvier in myelinated and all along the axon in the non-myelinated. So can you just tell about this sodium channels, the structure of these sodium channels? Don't go into details, basic structure. Where will be the local anesthetic receptor present in the voltage gated sodium channel? Is it in the proximal aspect of the sodium channel, or almost at the distal end, or in the middle portion of the sodium channel?
It has alpha and beta units, sir. Alpha with 4
Don't
domains.
worry about all those details about the ligands and all those things, alpha units, beta units, just about the sodium channels and where is your local anesthetic site of action, that is a receptor for local anesthetic.
At the ends.
Yeah, at the distal portion of the voltage gated sodium channel, you have, that means it is intracellular. The receptor for local anesthetic agent is almost intracellular because the sodium channel extends into the intracellular, already we have said, isn't it? So why should you know about this particular thing? Because the receptor is inside the axon. Why should you know?
Mechanism action, or is it something to do with the duration?
It can be in the resting state or can be
mechanism of action. Okay. So where it has to act intracellularly, isn't it? So it has to enter the axon, inside the axon, and then enter the sodium channel from inside, and then it has to associate with the receptor there, and it has to produce the effect. It has to block. So that means it has to enter the axon itself. It has to pass through the myelin sheath and enter inside. So why should you know about this?
Because of the unionized form.
Onset
Yeah, because it has to enter means it is only the unionized form of the local anesthetic, which is lipophilic. Ionized form, that is hydrophilic, cannot enter. So it is the unionized portion of the local anesthetic molecule, can enter inside and can produce a block, isn't it? So that is why, in order to know whether the local anesthetic onset of action is faster or slower or delayed, it all depends on how many molecules of the local anesthetics are in the unionized form, isn't it? So that is very, very important for us to know about. So what determines this ionization of the local
rate of dissociation?
PK.
Very good. Or dissociation coefficient or dissociation constant. What is this pKa? Can you just define pKa?
It's a dissociation constant at which 50% of the drug is in ionized form and 50% is in unionized form.
It is the pH.
pH.
Dissociation coefficient is the pH. At which 50% of the drug is the ionized portion and 50% is
50% will be unionized.
So that is log of ionized to unionized. So otherwise pKa is equal to pH plus log of ionized to unionized. So when it is 50% ionized and 50% unionized, it becomes log of 1. Isn't it? 50-50 means 1. So what is log of 1?
Something to do with the body pH, sir?
Log of 1 is 0.
Zero.
So that means the pKa will become equal to pH.
Yes.
That is how you should know about why it is always defined as it is that pH at which the unionized and ionized will be in equal quantities. That is log of ionized to unionized is 50-50. It is 1, log of 1. Log of 1 is 0. So now pKa becomes equal to pH. Almost Henderson-Hasselbalch equation, isn't it? So pKa is equal to, it becomes pKa is equal to pH. So more the pKa is more close to the extracellular pH or the plasma pH. So more number of molecules will be in the
unionized form.
Okay. Now what is the pKa of lidocaine?
7.9, sir.
7.8. Okay. What is the pKa of bupivacaine?
8.1.
8.1, and some books also give as 8.2. So bupivacaine, ropivacaine, levobupivacaine, all these are roughly 8.1 to 8.2. Okay, then chloroprocaine.
7.
It is less.
It's less than.
Chloroprocaine is also being used in India. It is available for intrathecal purposes. Shortest duration of action of chloroprocaine. One of our PGs also did his dissertation on chloroprocaine intrathecal. It is available now. So what is the pKa of chloroprocaine? It is 8.9.
Okay.
It is quite high.
Quite high. Okay, sir.
Yeah, because if the pKa is more, what happens to the unionized molecules? Number
Less.
will be less. Now, I'll tell you why it will be less. Like, for example, now we know the formula of or Henderson-Eisenbach equation is pKa is equal to pH plus log of ionized to unionized portion, isn't it? So if you bring pKa to the right side, or sorry, left side, that is towards, if you bring pH to the left side, it becomes now pKa minus pH, that is equal to log of ionized
and
unionized. You understood, isn't it? You are
Yes,
just
sir.
rearranging the equation. pKa minus pH will be log of ionized to unionized. So now we know the pKa of, let us say that lidocaine is 7.8. 7.8 minus 7.4 is how much?
7.4.
0.4, isn't it? If you have 0.4 on the left side, that is equal to log of 72 by 28. You calculate. So that will be, if you calculate log of 72 by 28, that is 0.4.
Okay, sir.
That means how many molecules will be in the ionized and how many molecules of lidocaine will be in the unionized form?
72 ionized and.
Pardon? No, you just give me the equation. 78 molecules in the ionized form. 28% or 28. So if you take 100 as the number, so percentage wise, 28% of lidocaine at 7.4 pH will be in the unionized form. 78% will be in the ionized form. Okay, let us consider about bupivacaine being 8.2. 8.2 minus 7.4 is how much?
0.8.
0.8, very good. So 0.8 log of the ionized to unionized is actually 86 to 14.
Okay.
That means how many molecules are unionized with bupivacaine?
14.
14.
14 will be unionized.
Now we have realized, isn't it? So this is to tell you how pKa will determine how many molecules have to be in unionized and ionized form. And we know that it's the unionized form which can
penetrate.
Cross the axon, bilateral layer of the axon, enter inside. Once it enters, what happens to this molecule?
pH, it becomes ionized form.
Yeah, it becomes ionized because what is the pH
plus.
inside pH? How much?
7.35.
Intracellular pH.
7.45.
Intracellular pH.
7.3, sir.
It is 6.8. Intracellular always acidic pH. Extracellular it is 7.4. Intracellular it is 6.8. So naturally what will happen is once it enters, it becomes ionized. And we should know that it is only the ionized molecules can associate with the receptor inside and can produce blockade. It is the unionized molecule can enter inside. It has to get converted to ionized form to produce the blockade. So this you should always remember. So now we have realized about the pKa, and so we'll come to the factors influencing the onset of action of local anesthetics. pKa is one of the most important factors. But we'll come to that slightly later. We'll complete with our how these local anesthetics act. And Nina was telling that there will be different states of these voltage-gated sodium channels. What are these different states they can exist?
resting state, sir, and
Yeah,
then
very good. Resting,
active and
active,
inactive, sir.
inactive, and one more.
Active and inactive and resting state.
state.
Three.
One is resting, active, or the open state, and
Partially
inactive, deactivated state. There are actually 4 states.
4 states.
That is resting, active or open, then inactivated state, and then deactivated. So you should remember local anesthetics can act only when either resting state or open and inactive state. Sorry, open state and resting state, they can. So when it is inactivated state and when it is deactivated, it cannot act. So, in each voltage gated sodium channels, there are 2 gates. One is outer gate and one is an inner gate. Can you just explain about these gates? What are they called as? So in order to know how the states will be there, you have to know about these gates inside the voltage gated sodium channel. Outer gate is called as what gate?
Intracellular and extracellular.
No, there are let us say that this is the voltage gated sodium channel. There is a gate here, there is a gate here. So both the gates have to be open for local anesthetics to enter and then act, isn't it? Or sodium has to enter and then produce depolarization. For producing conduction of the blood, conduction of the nerve, depolarization has to occur. Depolarization means what? Sodium has to enter, potassium has to come out. The transmembrane potential will change from minus 90 to plus side to produce depolarization. That is what is depolarization, that you should know. So for sodium to enter, the outer gate and the inner gate both have to be open. The outer gate is called as M gate. Inner gate is called as H gate. Just remember, you can write down like this, one tube like, which is the sodium channel. Outer you have the M gate and inner you have the H gate. During resting state, the outer M gate is closed, but H gate is open. So because of that, sodium cannot enter inside because the outer gate is closed. Sodium has to enter from outside. So resting, that is why no depolarization. Once an action potential comes, an impulse comes, what happens? The M gate or the outer gate will open. The inner gate is already open. The outer gate also opens. The sodium, molecules will enter, and potassium will be coming out from other channels, potassium channels. So there will be a change in the membrane potential from minus 70 towards higher voltage, towards plus side. And minus 50 is the threshold potential. Suddenly, more number of sodium molecules will enter. And that's how depolarization will occur. And the transmembrane voltage will be nearly plus 20. Okay. Now, this is called as the open state or the active state, where the outer M gate is open, H gate is also open. Now, what will happen is the inner H gate will close because it is almost like a time gated one. After a brief interval of time, some milliseconds, it will just close. Once it closes, no more sodium can enter. Though the outer gate is still open, M gate is still open, but sodium cannot enter. So depolarization stops, repolarization will start. Repolarization will start. So this particular state is called as the inactive state. Now you understood. Active resting state, the outer gate is closed, inner gate is open. Okay. Active state or the open state, the outer gate becomes open, the inner gate is already open, sodium channels are open, so sodium will enter, depolarization occurs. Once it reaches plus 20 millivolts, so now the outer gate still remains open, but the inner gate closes. So now depolarization stops. And the axon is, or the sodium channel is said to be in the inactive state. After a brief milliseconds, what will happen is the outer gate also closes. Now both the gates are closed. The outer gate is closed, inner gate is closed. This state is called as the deactivated. So depolarization cannot occur in the inactive state and deactivated state. Okay, now we understood, isn't it? So the other important things about this, in the resting state, it is only the unionized molecules of local anesthetics can enter because the outer gate is closed, isn't it? But when the active state and inactive state, the outer gate is open. Even the ionized molecules can enter and then they can reach the local anesthetic receptor site inside and can block. That means when this, nerve is being stimulated, when it's getting used, the local anesthetics can be effective still because even the ionized molecules can enter through the sodium channels because the outer gate is open. And what is this kind of a block called as? Where the block can be faster of the local anesthetic because even the ionized molecules can enter.
Basic.
Very good. Phasic block or use-dependent block. That means, if the patient has pain, the channels can be in the open or inactive state. Your local anesthetics can act faster. Or when you repeatedly keep stimulating the nerve when you are giving the block, so local anesthetics can block. And this kind of a block is called as use-dependent block or otherwise called as a phasic block. Otherwise, regularly when it is in the resting state and you are introducing the non-ionized molecules are entering, it is called as a tonic type of block. Tonic block, phasic block. So you should always remember. So use dependent. These are all the things which you have to write down whenever you are asked about the action of local anesthetics on the voltage gated sodium channels. Now, these are the few things about how the local anesthetics will act. Now, coming to the onset of action of local anesthetics, because we were discussing about the pKa and how pKa will help in more number of molecules in the unionized state. So naturally, if the more number of molecules will be in the unionized state, onset of action will be
faster.
Unionized
faster.
Yeah, okay. So now, what are the factors which influence the onset of action of local anesthetics?
Molecular weight, sir.
No.
Lower molecular weight.
No, first is pKa.
First is pKa.
You should always think about the pKa, isn't it?
Yes.
Most important is the pKa.
pKa.
The more pKa is more towards the normal pH.
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 More unionized form, faster.
More unionized and faster will be the onset. Like, for example, now we already gave lidocaine acts faster. Whereas bupivacaine being 8.1 or 8.2, it takes longer time. So one factor which influences the onset of action is the pKa. Okay. What is the second important factor? Lipophilicity, yes, okay. Onset of action, lipophilicity depends on the potency. For onset of action,
addition of adjuvants like soda bicarbonate.
Okay, that is again with the pKa only.
Or we can add adrenaline, sir. Causes that also onset of action is faster.
No, with adrenaline, onset of action is faster or delayed? Now you have
onset is faster.
Started otherwise I would have asked you later. No, you have generated this discussion. Okay, adding adrenaline will produce
duration. Increases the duration.
It doesn't increase the duration.
Talk about the duration now.
It's just the onset only.
In the onset of action only. Yet.
So it doesn't. It constricts the vessels around.
Don't worry about those things. That all the duration of action. So we are still in the onset of action. So adrenaline and onset of adrenaline as an adjuvant. So what happens to the pH of the local anesthetic agent when you add adrenaline? For example, lidocaine. So what is the pH of plain lidocaine?
Plain lidocaine is the pH. pH
They're
is only what it is,
basically all local anesthetic agent. One thing you should always realize, they are all weak bases.
sir.
But when they are in weak bases, they cannot be diluted with water. They
Yes.
cannot, they are not dissolved, they are not going to be dissolved in water. So in order to make them to get dissolved in water, they have to be made as salt by adding acids and
Right.
to bring the pH down. Then only they can be diluted with water, and then they can be, shelf life will also be very good, and they are prepared like that. That's why you must have seen lidocaine hydrochloride, bupivacaine hydrochloride, because hydrochloric acid has been added. Though they are weak bases, now what happens to the pH of these prepared lidocaine or bupivacaine and all? So what is the pH of plain lidocaine hydrochloride?
6.
Very good.
Agree 4.
It is 6.6. Still, it is more towards acidic only. Only once you inject, so they get separated. The hydrochloride, chloric acid gets separated, and then lidocaine become base with the pK of 7.8, and all those things will occur. Now, when you add adrenaline, what happens to the pH of the lidocaine?
Further acidic, sir. 4.
Very good. Further acidic, and what is the pH? Now from 6.6, it drops down to
4.4, 4.5.
yeah, 4.4. It drops down to 4.4. That means it becomes more acidic. If it becomes more acidic, what happens to the number of molecules in the unionized state?
Decrease.
Less decreases.
So what happens to the onset of action?
Slower.
Supposed to be
Yeah, delayed.
yeah.
Now, Anup, I think you have understood now, isn't it?
Understood, sir. Understood.
So when you add adrenaline, actually the onset of action gets delayed. So it will not hasten the action. But that is why, freshly prepared lidocaine with adrenaline, the pH still will remain at 6.6. Just, you prepare now, you add adrenaline to lidocaine and then immediately you inject.
So
then
the onset
it will not have dropped. Pardon?
The onset when you are injecting adrenaline with a local anesthetic will be quicker, no, sir?
No, when you add adrenaline, just now you prepare a freshly prepared lidocaine with adrenaline.
Because of the acidic
can act, will not be so acidic. Already prepared one. What we have, lidocaine with 1 in 2 lakhs adrenaline.
Okay.
That pH will be quite low because there will be a better mixing will be there, and that produces a decrease in the pH.
Okay.
And what particular component of adrenaline will make adrenaline to be more acidic? Which particular component or preservative of adrenaline will make it more acidic? It is sodium metabisulfate.
Sodium metabisulfate.
See, adrenaline ampule, you take adrenaline ampule or you take lidocaine with adrenaline. Sodium metabisulfate is the preservative that is there with adrenaline. And it is the sodium metabisulfite which actually produces more the pH to come down of the preparation one. So it comes down to 4.4. That is why the onset of action is delayed. One more effect of this lidocaine with adrenaline, as far as when you are using successively the same, for example, now you have got an epidural catheter and you are giving only lidocaine with adrenaline against subsequent doses. What happens to the subsequent doses when you give lidocaine with adrenaline? What happens to the required dose? The required dose will increase or decrease? Normally, when we give repeat doses with epidural catheter, we give half the original dose normally, because already molecules are present. You are just adding, isn't it? So with lidocaine with adrenaline, when you are using repeat dose, the problem is acute tolerance will occur. Otherwise,
give more. Okay.
Yeah, you require more and more dose to get the same effect. And that is again because of sodium metabisulfite. Again, because the local pH, it is going to drop. So less number of molecules in the unionized state. And that is the problem that can occur with sodium metabisulfate. Just remember about this. You may be asked in the Viva about this particular preservative of adrenaline with local anesthetics. So onset of action, one is the pKa. Okay, what is the very important thing about second important factor which influences the onset of action?
Molecular weight, sir.
Not the molecular weight. The concentration and volume.
Volume.
Higher the concentration used, more number of molecules are available. Isn't it? So they rapidly act. You just remember, for example, I use 0.5% lidocaine and 2% lidocaine or 5% lidocaine. 5% lidocaine definitely will act very rapidly when compared to 1% lidocaine or 0.5% lidocaine. So, or bupivacaine, 0.25%, 0.75%, 0.75%, 0.5%. 0.5% will act faster when compared to 0.25. So, second thing is concentration of the drug, what you use. So, then third thing is the preservatives that is used. Especially, for example, now adrenaline, onset of action gets delayed. But you also mentioned about sodium bicarbonate. Now, you just tell me how sodium bicarbonate helps in, faster onset of action.
As you said, lidocaine is a weak base. So sodium bicarb is also a base. So you're adding a base with a base. So there is a lot of unionized molecules which is available.
What happens with the pH?
pH.
You are increasing the pH.
Yes, yes.
No, actually, I told you lidocaine hydrochloride has a pH of 6.6. Now, once you add sodium bicarbonate, it may come up to 7.4 or 7.6.
Close to the body pH.
Yeah, close to the body pH, isn't it? So that's how sodium bicarbonate can make more number of molecules available in the unionized state. So that's how the onset of action can be fast. So it is going to help which particular form of lidocaine? Is it plain lidocaine or lidocaine with adrenaline?
Plain lidocaine, sir.
No, it can help more with lidocaine with adrenaline, isn't it? Lidocaine, plain lidocaine can be acting faster only because its pH is 6.6.
Asking which will be
adrenaline pH is 4.
Okay, sir.
Adding bicarb to this lidocaine with adrenaline
will prolong the increase the duration.
Increase the onset of shorten the onset of action, isn't it? Shortens the duration of onset of action. So it's going to help lidocaine with adrenaline rather than plain lidocaine. You can add sodium bicarb to lidocaine with adrenaline. Suppose if you want to hasten the onset of action of lidocaine with adrenaline, otherwise it will take longer time. For example, now I want to use lidocaine with adrenaline for epidural. Because majority of the times we always use lidocaine with adrenaline and afterwards subsequent doses will go for bupivacaine. Because we want it to act faster so that afterwards you can always use bupivacaine. That is why same thing for brachial block and other things also you can always use first. And plain lidocaine you will not be using because it is always better to use lidocaine with adrenaline because you can use more higher dose because the toxicity will be less with the lidocaine with adrenaline because absorption will not occur. So that's how majority of the times we'll be using lidocaine with adrenaline rather than plain lidocaine for infiltrative blocks or even for epidural. So because you know that you are using that to hasten the onset, so because we know that adding adrenaline would delay the onset, so adding sodium bicarbonate will have an faster onset of action. So how sodium bicarbonate? One is it is going to increase the pH, make it more alkaline. The local pH also will increase when we inject. So more number of molecules will be in the unionized state, so they can penetrate better. Now, what other effect is also there with sodium bicarbonate? Now, once you inject sodium bicarbonate along with lidocaine, what happens to this sodium bicarbonate?
It absorbs water, it becomes acidic. So
yeah, very good. It gets converted to carbonic acid. And carbonic acid dissociates into carbon dioxide and water. And what happens to this carbon dioxide? It's a volatile acid. Can it enter the intracellular, area from extracellular? Can easily penetrate. Bicarbonate cannot penetrate. But carbon dioxide can enter the axon inside. Once it enters carbon dioxide, I told you it is an acid. Again, it gets converted to carbonic acid inside. What happens to the pH inside the axon or inside the neuron cells?
Comes down.
Yeah, comes down. So what happens to these molecules which have entered?
Ionizes and then acts.
They become more ionized.
More ionized.
More ionized means where they can better block.
Block T.
Because for blocking, it has to be ionized.
Yes.
Entering, it has to be unionized. So that's how, that is another advantage of adding sodium bicarbonate. One more thing is, once they get ionized, they cannot come out of the neuron. They get trapped. This is called as ion trapping. That is the third advantage with sodium bicarbonate, because carbon dioxide entering, and once they get trapped, they produce a longer duration of action. So these are the advantages of using sodium bicarbonate along with lidocaine. One is onset of action is faster. Second thing is duration of action can also be longer. Okay, so now you tell me what is the amount of sodium bicarbonate you can add for lidocaine with adrenaline?
1 milliequivalents per. So I read it as 1 milliequivalents
1 milliequivalent
per.
No, you had a lot of time, Anup and Nina, for studying local anesthetics. These are the basic things about local anesthetics.
Equivalents per 8 ml, something like that.
Pardon? So you had 1 milliequivalent for 1 ml of lidocaine.
Lidocaine, okay, sir.
1 milliequivalent for 1 ml.
1 ml.
So, but you have sodium. What is the concentration of sodium bicarbonate you have?
8.4%.
Okay, 8.4%. Now you have 8.4%. Now you have to add 1 milliequivalent. How much you are going to add? How much you are going to add? 1 milliequivalent you have to add. What is 1 milliequivalent of 8.4%? How many ml?
0.8.
No, you have to know as an anesthesiologist. Otherwise, what is the, you know the theory that 1 milliequivalent has to be added. But practically, you have to know what is 1 milliequivalent of 8.4%. How many ml?
1 ml. I think 1 ml, sir.
Why 1 ml? How did you get this 1 ml?
Because in commonly practice, we use 1 ml, sir.
Now, you see, for that, again, basic things you should know. For converting, the ml or whatever it may be to milliequivalents. Milliequivalents is always for liter, per liter, isn't it? Now you have to know that mass divided by the molecular weight per liter, you get in milliequivalents. Mass of the drug. Now, when I say 8.4%, how much will be actually the mass of the drug will be there? In 100 ml, then 1000 ml. Because per liter you have to calculate. What is 8.4% means? Percent. Already we have discussed.
84 milligrams. Per ml.
No, 8.4%. 8.4% is 8.4 grams in 100 ml. Did you understand? When you say 2%, 2 grams per 100. 1%, 1 gram per 100 ml. Like that, 8.4% means 8.4 grams per. You have to convert into milligrams. Because I told you, mass in milligrams divided by molecular weight per liter. You get so many milliequivalents per liter. That's how you calculate. All these things you should note down because these are very important, the basic things regarding the biochemistry. So now 8.4 grams is how many milligrams?
0.0.
No.
Divided by 1000.
8.4 grams is how many milligrams? 8,400 milligrams. 8,400 because 1 gram is, How many milligrams?
1000 milligrams.
So it becomes 8.4,
8.8400 milligrams.
Now per liter you have to calculate, isn't it? So this is for 100 ml. So now from 8.4 grams, it becomes 84 grams in 1000 ml.
1000.
You understood, I hope.
Understood, sir.
I think Anup is good in maths, it seems.
Yes, sir.
Following it very fast. So 84 grams. 84 grams is how many milligrams?
8400.
84,000.
84,000.
84,000 milligrams. Because 8.4 was 8,400. 84 grams is 84,000.
84,000 milligrams.
And that divided by the molecular weight. Now you have to know what is the molecular weight of sodium bicarbonate. What is the molecular weight of sodium bicarbonate? See, these are very important. You should know. This is not given in any of the books. You have to really search for it. That's how, these discussions will help you. Now, what is the molecular weight of sodium? You have a pen and paper?
Yes, sir.
You just write down. What is the molecular weight of sodium? Sodium is 23. NaHCO3. NaHCO3 is sodium bicarbonate. Yeah, 23 is the molecular weight of sodium, Na. H is 1, hydrogen 1.
Okay.
Carbon C is 12. And O3, that is oxygen, is 16 into 3 is 48. Now you add 23 plus 1 plus 12 plus 48.
80, 60, 70, 80,
84.
83, 84.
84, isn't it? Now you know why 8.4% that has been made. Otherwise, it is quite unusual, isn't it? 8.4. Now, 84,000 divided by 84. You get so many milliequivalents per liter. What is 84,000 divided by 84? You write down and
1,000.
yeah, 1,000 milliequivalents in how many ml?
In
Per
1
liter.
liter per liter, sir.
So 1,000 milliequivalents in
1 liter.
1 liter means how many ml?
1000
ml.
1000.
1,000 milliequivalents in 1,000 ml. 1 ml contains how many
1
ml?
ml. 1
One
milligram.
contains 1 milliequivalent. Now you know 8.4% means 1 milliequivalent means how many ml?
1
8.4 ml.
1 ml, 1 ml.
1
1
ml is
ml.
1 milliequivalent.
1 ml. 1 milligram.
That is why it has been made 8.4%.
Understood, sir.
Before it was coming as 7.5%. Now they have changed it to 8.4% so that the calculation can be very easy. Now you know that every ml of sodium bicarbonate has 1 milliequivalent. Every ml is equal to 1 milliequivalent. And the derivation I just told you. Because mass in milligrams divided by the molecular weight, per liter you get the milliequivalents per liter. Mass of 8.4% per liter is 84,000 milligrams. And that divided by the molecular weight of sodium bicarbonate is 84. You get 1,000 milliequivalent in 1,000 ml or 1 milliequivalent per 1 ml. So for 1 ml of lidocaine should be added with 1 milliequivalent. So for 10 ml, you add 10 milliequivalents, means 10 ml of sodium bicarbonate. Now understood, isn't it? So that's how, sorry, for 10 ml, you add 1 ml of sodium bicarbonate. 10 ml of lidocaine. At
1 ml.
1 milliequivalent of sodium bicarbonate. Not for 1 ml, 1 ml, no. For 10 ml, 1 ml. That's how you should know. Suppose you have 7.5% sodium bicarbonate. How many ml you will be adding for 10 ml of lidocaine?
1 ml.
For no 7.5% means it cannot be 1 ml is not 1
No, not
1 milliequivalent.
75 divided by 80.
84,000 divided by Not 84,000, 75,000 divided by
5,000 divided by 80.
84. You get 0.9 roughly.
892 point something.
0.9 roughly. 89 means you can say 0.9.
0.9.
So 1 ml of this will have 0.9 milliequivalents. So 1.1 ml will be 1 milliequivalent. Did you understand?
Yes, sir.
So if you have 7.5%, for 10 ml of lidocaine, you have to add 1.1 ml.
1.1.
If you have 8.4%, you just add 1.
1 ml. Okay, sir.
That's how you add. Okay. So these are all the very important things about the onset of action of local anesthetic agent.
Correct.
Now, the other important thing, so onset of action depends on the pKa. So pKa is very important, and higher the pKa, the onset of action is quite delayed, isn't it? So that's how, bupivacaine acts later than lidocaine. Lidocaine acts earlier than bupivacaine, isn't it? So these are important things you should always know about. Whereas, what is the pKa which is least as far as, no, we said that the highest pKa is 8.9 of chloroprocaine. So the onset of action of chloroprocaine will be, much later when compared to lidocaine, bupivacaine and all. But that has been, taken care of by using higher concentration of chloroprocaine for intrathecal use. In US, intrathecal chloroprocaine you get is 3% chloroprocaine. Very high concentration of chloroprocaine is used. 3% is high as far as chloroprocaine is concerned. So it acts quite fast, because the other factor which is also important is the concentration that is used. That is why these factors which can influence the onset of action you should know. It is as fast as lidocaine because you're using 3% chloroprocaine intrathecally in United States, and it is majority of the times it is used for cesarean sections, because the duration of action of chloroprocaine is very short.
Very short.
30 minutes or 40 minutes. So that is enough for cesarean section, so that, the early mobility will be there for the mother. And if you add an opioid, so analgesia will be there, but motor blockade will not be there. So DVT chances in the postoperative period can be decreased. So that's how, chloroprocaine is used. Another advantage of chloroprocaine is, it's a ester local anesthetic. It is not an amide local anesthetic.
Amide. Ester.
Because it is an ester, all esters are, how esters are metabolized?
Pseudocholinesterase.
Yeah, by pseudocholinesterase. What is the exception here? Which is the ester which is not metabolized by pseudocholinesterase?
Tetracaine.
Tetracaine is also metabolized by pseudocholinesterase. Which ester is not metabolized by pseudocholinesterase? The first local anesthetic that was introduced.
Cocaine.
Cocaine. Cocaine is not metabolized by pseudocholinesterase. It is metabolized by the hepatic carboxyl cholinesterase. That means it requires liver for its metabolism, cocaine. All other esters are metabolized by pseudocholinesterase. Okay. How amides are metabolized?
Liver cell dealkylation.
Yeah, all of them are metabolized in the liver by phase 1 and then phase 2 react. So what is the exception here? Which amide local anesthetic agent is not metabolized by metabolized in the liver, but again metabolized in the plasma by plasma cholinesterase? Amide local anesthetic.
82.
Huh?
See.
82.
No. Articaine. Of course, we are not using that articaine much. Dentists use articaine quite a bit. So articaine is metabolized by pseudocholinesterase. That is exceptions. This exceptions you should know. Cocaine is metabolized in the liver, though it's a ester local anesthetic. Articaine is metabolized in the plasma by plasma cholinesterase. Plasma, not pseudocholinesterase, plasma carboxyl esterase. Articaine is metabolized. So it does not require liver for its metabolism. So these are some of the exceptions. So chloroprocaine, because it is an ester local anesthetic agent, you can use higher concentration because it won't produce any toxicity because it is rapidly metabolized in the plasma itself. That's how, higher concentration is used for producing spinal anesthesia of chloroprocaine. So this is another very important thing you should know about. Okay, now the other important thing is the duration of action of local anesthetic. So what are the factors which influence the duration of action?
Lipid solubility and
Duration of action. Nothing to do with the lipid solubility.
Protein bindings.
Yeah, very good.
protein binding.
One is the protein binding. What is the second factor which helps in the duration of action?
Quantity and strength. I think.
Concentration used, isn't it? Higher the concentration used,
Concentration more than
the more molecules will produce more prolonged. What is the third factor?
Route of administration. Sorry.
Site of injection,
injection.
Vascular.
where you have injected.
Injected.
Okay, these three are the factors. One is, I told you, protein binding. Which protein these local anesthetics are bound to?
Alpha 1 alpha 1 glycoprotein.
Alpha 1 acid glycoprotein.
Glycoprotein.
So you should always remember this. Alpha 1 acid
Acid
glycoprotein is called as AAG. Alpha 1 acid glycoprotein. Where this is alpha 1 acid glycoprotein is synthesized.
Liver.
Yeah, it is again synthesized in the liver. So why should you know that alpha 1 acid glycoprotein is synthesized in the liver?
Because in infants less than 6 months, this amount will be less. So
Yeah, very good. That is one. Wherein, there will be more free drug availability will be high in neonates and infants. So toxicity can be very high in neonates and infants. And what other things about alpha 1 acid glycoprotein? Quantity.
burn patients,
Alcohol.
this will be very high.
No, again, in patients with liver disease, alpha 1 acid glycoprotein will be less.
Less.
So more prone for toxicity, you'll have to reduce the dose. And where else it gets diluted and becomes less?
Cirrhosis.
Pregnancy.
Pregnancy.
Cirrhosis, liver disorders, there is definitely reduced, synthesis itself is reduced. Whereas in pregnancy, like albumin is also diluted. Like that, alpha 1 acid glycoprotein is also diluted. So again, free drug concentration will be high. So that you should know about the protein binding of these drugs. So higher the protein binding, duration of action can be longer. How this protein binding produces longer duration of action? How does this produces longer duration?
Transport.
No, all along the axon, nerve fiber and tissues nearby, a lot of proteins will be there, isn't it? When you inject, these drug molecules will get bound to these proteins there. And this protein binding there locally is a dynamic process. Whenever the concentration inside decreases, the molecules will get detached from the protein and start entering into the nerve fiber and start acting. That's how, once they get bound to the protein there, they'll not enter into the blood to get metabolized, isn't it? Because they're bound to the protein.
Okay.
So that is how, the duration of action increase. The protein binding is very, very important as far as the duration of action is concerned. And, what is the protein binding of lidocaine? How much it is protein?
Lidocaine is 65, sir. 65%.
Yeah, roughly about 65% protein bound. That is why the duration of action is intermediate, isn't it? Because more molecules now get into the blood faster, gets metabolized and excreted out. Whereas bupivacaine, ropivacaine, etidocaine, levobupivacaine, how much they are, protein bound.
Percentage. 94, 95.
Yeah, 95% of. So that is the reason why the duration of action of these drugs So bupivacaine, ropivacaine, levobupivacaine, nitidocaine, lidocaine is very longer. That is how, that is another very important thing about the protein bodies. Second thing I told you is the concentration. Higher the concentration, that you need not have to know about. Definitely, longer will be the duration of action. For example, I use 0.5% of bupivacaine and 0.1% of bupivacaine. Definitely, 0.5% bupivacaine will produce a longer duration of action. So that is another one. The third thing I said is the site where you inject. If there is increased vascularity of the space, so what happens to the duration of action?
Reduced.
Reduced. It is obvious, isn't it? So can you just tell, based on usually you inject drugs, the vascularity of the areas. Do you have any mnemonics to remember that? Highly vascular, then next less vascular, like that. Any mnemonics you know of to remember? It is biceps. BICEPS. Double S at the last.
Okay.
Biceps is BICEPSS. So B stands for, the blood itself or trachea, transtracheal. If you inject the drug into the blood, the duration of action is very short. Which drug you are going to inject which local anesthetic into the blood?
Lidocaine.
That is lidocaine. Don't say Xalacard. Xalacard is a trade name. Preservative-free lidocaine. So that means the duration of action is just about 10 minutes. Very short duration. So B stands for blood and trachea also. Transtracheal. Which drug you can also use through the transtracheal route? For example, now you have got intubated patient, you don't have an IV line. You want the drug to be given, administered, so that it can act faster. Which are the drugs that can be introduced or administered through the transtracheal route? What is the mnemonic to remember that? Transtracheal administration. One of the drugs is lidocaine. Other drugs I am asking. You can remember it as navel. Navel. Navel, the umbilicus. Navel, you can remember. N stands for naloxone. A stands for atropine. Na. V stands for vasopressin. E stands for epinephrine. L stands for lidocaine. So these are the 5 drugs which can be administered through the transtracheal route, through your endotracheal tube. You can easily administer these. Okay. So now coming to the mnemonics of biceps. So B stands for either blood or transtracheal. So I stands for, which is the other highly vascular other than the blood itself. Next vascular is intercostal and interpleural. Intercostal and interpleural. So intercostal block or intrapleural block, when you use, the duration of action is short because highly vascular. And then C stands for what? Caudal. The next less vascular is caudal. And still less vascular is epidural. E stands for epidural. And then P stands for perivascular brachial plexus, where the interscalene or supraclavicular or axillary block, these are all perivascular we are injecting. So this is perivascular brachial block. And then SS stands for S stands for what? Sciatic bar femoral. Sciatic bar femoral, where you inject around the sciatic nerve or the femoral nerve. So the least vascular. Then the other least vascular is subcutaneous. Another S. So highly vascular blood and trachea. Next is intercostal and intrapleural, then caudal, then regular, lumbar epidural, thoracic epidural, and all those. Then perivascular brachial plexus. Then S stands for sciatic bar femoral. Another is subcutaneous. So now if you think based on the area where you inject, the longest duration will be where? Because absorption will be least.
Subcutaneous.
Subcutaneous sciatic femoral, isn't it? Longest duration here because absorption, because the local anesthetic molecules have to absorb into the blood and have to be metabolized. If they are there at the local site, they can continue to act. That is what is another important thing about. And another important thing about these is, these areas are the ones where the maximum toxicity can occur. Higher the vascular supply, maximum toxicity, because
But
blood
absorption is
concentration will rapidly increase. Did you understand that?
yes, sir.
Okay. This is about the duration of action. So duration of action, three things: protein binding, concentration you use, that
And
is
site.
the site where you administer the drug. So that is another important thing. Again, the potency of the drug depends on what?
Lipid solubility. Lipid solubility.
Yeah, lipid solubility. Can you just tell me the lipid solubility numbers of all these commonly used local anesthetics? What is the lipid solubility number for lidocaine?
Then right.
It is 336. Lipid solubility number, lipophilicity number, it is called as. It is for lidocaine, it is 336. For ropiocane, it is 100. So probably you don't know about this, isn't it? So ropiocane, it is 760. 360 for lidocaine, 760 for ropiocane. And bupiocane, it is 3620. And etidocaine, it is 7600. Now, with this lipophilicity numbers, which is most potent and which is less potent now with these numbers?
Is potent.
336 no? While
Lidocaine is least potent when compared to these four drugs, what we routinely use, isn't it? Etidocaine is highly potent, highest potency, but it is not used in India. So if we are using lidocaine, ropiocane, bupiocane, levobupiocane. Notice again the levobupiocane and bupiocane lipophilicity number is same. It is 3600 number, 3620. So both bupiocane and levobupiocane. Okay, so what is the difference between bupiocane and levobupiocane actually?
The isomerism, sir.
Which one is isomer? Which one is a racemic mixture?
Yes.
Now, which one has got two isomers, both dextroisomer, and which one has got only the levoisomer?
Isomer is bupivacaine.
Pardon?
Bupivacaine has two isomers, sir.
Yeah, two isomers or enantiomers also you can say.
yes, sir.
So enantiomers, what is the difference between just an isomer and an enantiomer? So difference between isomer and isomers will have the same number of the molecules, sorry, same number of ions, whatever may be the chemical structure, it is the same number will be there, but their position will be different. Whereas enantiomer, the two enantiomers, the mirror image of each one. They'll have a mirror image.
Image.
For example, carbon atom on this side for other isomer, the carbon atom will be in the opposite side. So they are mirror image. They are called as enantiomers. Okay, so now actually these are bupivacaine is an racemic mixture. It contains both dextro and levo enantiomers, or you can all they are isomers, but because they also have the mirror image of each one, they are called as enantiomers. So it has got dextro and levo isomers.
Isomers.
Whereas if you separate the levo isomer from bupivacaine, you have the levo bupivacaine. That is the difference. It all depends on how they rotate the optical light. Dextro isomers will rotate the optical light towards the right. Levo one will rotate this thing to the left. Or dextro will clockwise rotation they produce, levo will produce anti-clockwise rotation. There are also you can also say R isomer and S isomer. R isomers are dextro isomers. S isomers are levo isomers. Now your levo bupivacaine is which isomer? S or R?
Yes.
Yes, isomer. S is levo. R is dextro. That is what you should know. And you should also know why they, because there is absolutely, as far as onset of action, the pKa, the lipophilicity, the protein binding, everything is same between bupivacaine and levobupivacaine. But why we have levobupivacaine? Why we want only the levo variety?
Lesser cardiotoxic, sir, compared to.
Yeah. It is the dextro isomer of bupivacaine, which produces the cardiotoxicity. So less cardiotoxicity with levobupivacaine. That is why the S isomer of bupivacaine is separated, and we are using it as levobupivacaine. What about the ropivacaine? Is it a racemic mixture, or is it a isomer or enantiomer? Ropivacaine.
Dextro
I think so.
rotational isomer.
I told you the dextro isomers are cardiotoxic. So ropivacaine cannot be dextro isomer. It is a levo S isomer or S enantiomer of propivacaine.
Okay.
Propivacaine. So propivacaine is an racemic mixture, and if you take out the S isomer from propivacaine, what you have is a ropivacaine. That is why ropivacaine is also less cardiotoxic. So these structural changes you should always know about of these local anesthetics. So that is the important thing about the lipophilicity and their the potency. And another very important thing is lipophilicity is also equally important as far as the toxicity is also concerned. Highly lipophilic drugs are more toxic when compared to less lipophilic. Like that's why lidocaine is much less toxic when compared to ropivacaine, bupivacaine, especially bupivacaine. That's why lidocaine we also introduce intravascularly because it's cardiotoxic. We will come to the toxicity later at the end of our discussions. So that is what we should always understand about. So now the other important thing is we'll come to the individual local anesthetics. So almost majority of the things we have already discussed about many of these local anesthetics. So coming to the lidocaine hydrochloride, it is always as a salt, lidocaine hydrochloride, because lidocaine itself is unstable. And that is why in order to make it more stable, it has to be added with hydrochloric acid. That's how, but unfortunately its pH will come down from more basic to acidic. It becomes 0.6. So the onset of action still gets slightly delayed. So you have many preparations of lidocaine, isn't it? So what are the preparations of lidocaine you remember? Can you just tell?
You have local anesthesia, cream emulsion form.
Pardon?
Spray.
Vials, vials, sprays, topical
No,
sprays,
you have
Lidocaine jelly.
infiltrative form. That is what it is, 2%, 1% for infiltration. That is for local anesthesia infiltration you are using, 2%, 1%. Okay, then you have with and without
Adrenaline.
lidocaine, 1% with adrenaline, 2% with adrenaline. Okay, then do you have
Topical jelly.
pardon, topical?
Jelly, sir.
No, topical, first is topical, comes in bottle, the liquid form, which is used for oral.
2% spray.
What is the
2%.
topical one? What is the concentration that is used?
4% spray.
4% topical, yes.
Topical.
For spray, what is the concentration you get? Spray, lidocaine spray.
2% ounce.
10%.
10% spray.
Spray is 10%.
10%.
Okay, jelly, lidocaine jelly, what percentage?
So
No,
liquid.
using
2%.
That only 2%.
2%. Okay, ointment,
Ointment is 2.5.
1.1.
5%.
5%.
Ointment is 5%. Lidocaine patch is also available. Lidocaine patch, what is the percentage? 5% lidocaine. Okay. Then you have lidocaine viscous. Viscous is how? What is the percentage? Viscous is 2%. Okay. You have intrathecal lidocaine. Of course, now we are not using intrathecally. What is intrathecal lidocaine? What percentage?
1% to 2%.
5%. 5% lidocaine with 7.5% dextrose. That is what we were regularly using for intrathecal purposes. Now we are not using for intrathecal lidocaine, though it was extensively used by us. We were routinely for all cesarean sections only lidocaine, 5% lidocaine with 7.5% dextrose, hyperbaric lidocaine. Why we are not using now lidocaine intrathecally? Why lidocaine is now, intrathecal lidocaine is not available at all, almost. But you ask many of the older anesthesiologists, they still prefer for cesarean sections lidocaine itself because of its shorter duration of action compared to BPOK. Onset of action is very rapid, but duration of action is short. That is enough for cesarean sections. Why it's not being used nowadays? Why?
Because of the toxicity, sir, because more amount of volume has to be used. So
no, you don't use more amount. It is 2 ml ampules. 5% lidocaine. 5% means it's already highly concentrated one. So volume you use is just 2 ml. 1 point for cesarean section you require only 1 ml.
okay.
1 ml is enough. But why it was producing transient neurological symptoms? TNS was more common with lidocaine, and that's how it was withdrawn. So from 2002 onwards, it has been withdrawn because various papers were presented. About case reports of lidocaine when it is given intrathecally producing transient neurological symptoms of nerve toxicity, direct nerve toxicity if the spinal nerves. Because the spinal nerves are raw, they are not covered by dura mater and arachnoid matter, they're just floating inside. So they're more vulnerable for lidocaine toxicity. That's how it has been withdrawn. But it is still available. Neon still manufactures it. And many of the anesthesiologists may be still using it. Because I have used extensively lidocaine intrathecally, I have not come across even a single case of transient neurological symptoms. Very rare complication, but because of this, only now lidocaine has been withdrawn, 5%. Now, why I am asking you is, now why so many preparations are there with different concentrations? Why you cannot have the same concentration for all? Why you have And also you have intravascular lidocaine without preservative of, 2% that is available, isn't it? Otherwise, what is the normal regularly bought preservatives that is used along with lidocaine? Lidocaine, bupivacaine and all. Which is the preservative that is used?
Sodium metabosulfate.
No, that is with adrenaline. Now, what is the preservative that is used? That means you people have not seen and read the vial, what it contains. What is the preservatives that are there with? How many times you have used 2% lidocaine for, brachial block or subcutaneous anesthesia, infiltrative anesthesia? Have you used or you have not used?
Use, sir, multiple times.
Almost every day you are using. Why you have not read the, label outside? What is the preservative? It is methyl or propyl paraben. Methyl paraben or propyl paraben. That is the preservative that is used. With lidocaine that is used intravenously, you don't have preservative. This methyl paraben and propyl paraben you don't use because they can produce more toxicity. One. And for intrathecal also, you don't have this methyl paraben and propyl paraben, preservative free. For example, bupivacaine or ropivacaine. Intrathecally, when you want to use, they are always preservative free because the preservative itself can produce neuronal toxicity. Otherwise, why should you know that the preservative is methyl paraben or propyl paraben? What happens to this preservative asset? What is the metabolite of this methyl and propyl paraben?
Toxicity, so increased chance of tox.
No. What is the
Metabolite.
metabolite? When it gets metabolized, this methyl paraben and propyl paraben, they get metabolized in the liver.
Para-amino-benzoic
Para-amino
benzoic acid, sir.
benzoic acid, PABA. Para-amino benzoic acid. And what is the problem with para-amino benzoic acid? The problem with
Causes the
para-amino
tox-
benzoic acid is, yeah,
Neurological and
no, not neurological.
cardiovascular risk.
More of, allergic reactions and anaphylactic reactions. Plain lidocaine will not hardly produce any allergic or anaphylactic reaction. Amides do not usually produce. It is because of the preservatives that is there, methyl paraben and propyl paraben, getting converted to para-amino benzoic acid, which can induce allergic manifestations and even anaphylaxis. That you should always understand. And we don't use, that's why intravascularly, intrathecally, even ideally epidurally also, you should not use a preservative containing local anesthetics. What about esters? What is the metabolite of ester? All these esters like, procaine, chloroprocaine, tetracaine, because they get metabolized by pseudoconal esterase. What is the metabolite? It is again PABA. All these esters, they get metabolized to PABA, para-amino benzoic acid. Same thing. That is why, esters produce a lot of anaphylactic reactions and allergic reactions. You must have heard about procaine penicillin. Have you heard about procaine? Nowadays, we hardly use procaine penicillin because it was the procaine which was producing anaphylaxis and anaphylactic reactions. And many patients used to die also with penicillin during our days because it was the only, better antibiotic that was available. A lot of patients used to be given procaine penicillin. And invariably, procaine used to get converted to PABA and PABA used to produce anaphylactic reactions. That is why, that is one of the reasons why esters we hardly use nowadays. Because they get converted to metabolite is the PABA. And that is why we hardly use. And another reason is they're short acting and less potent. All these are the reasons why esters are not used much. So, but we have so many preparations of lidocaine, like we have 1 and 2% for infiltration and 5% for intrathecal, 5% for ointment, 2% for jelly, and 2% for viscous, 4% for topical, and 10% for again lidocaine spray, and for patch 5%. All these things, I still remember one of our co-examiners were very fond of in the exam. So he used to keep all these things on the table when the student comes and sits in front. And then he used to tell, you just tell what are the uses of different preparations, with adrenaline, without adrenaline, all those things. And you have with adrenaline again, 1 in 2 lakhs, 1 in 1 lakh, 1 in 80,000 pounds. Have you seen 1 in 80,000 lidocaine with adrenaline? Adrenaline being 1 in 80,000. Where it is used?
180,000.
Where this is used? Lidocaine, 2% lidocaine with 1 in 80,000 adrenaline.
Dental.
Yeah, very good. So, dental anesthesia. There they want, highly vascular gums. So they want prolonged duration of action and less absorption. So 1 in 80,000 is used. So you should tell me tomorrow why different preparations. We'll continue tomorrow of local anesthetics, same time, 5 o'clock. Okay. So still probably about 30 minutes or 45 minutes we can continue. And then we will, next topic we'll take up is muscle relaxants we'll take. So I don't know who will present the muscle relaxants, pharmacology of muscle relaxants like depolarizers, non-depolarizers, and then reversal agent. Reversal agents like neostigmine, atropine glycopyrrolate, and Sigmund. Those things immediately after local anesthetics we can discuss about. Okay, tomorrow we'll continue with local anesthetics. So you should read about these things, why different preparations of different concentrations. And we'll continue with the individual local anesthetics. After finishing individual local anesthetic agents and their uses, then we'll go for toxicity of local anesthetic agents, the management of toxicity, the symptoms. That is also 10 marks theory question also. And invariably you'll be asked, what is the maximum dose you use? How do you manage the toxicity? And then also we will discuss about the newer preparations of the local anesthetics. So that will conclude the local anesthetic pharmacology. Okay, so any doubts till now what we have discussed? It's exactly 7 o'clock now. So you may have a lot of doubts. Tomorrow, first thing what we start with is the doubts you have. Then we will go ahead with the continuation of discussion. Okay. Okay then, Anup and Neena. Tomorrow we'll continue with our discussion.
Sure, sir.
Right.
Thank you.
Thank you.
Thank you.
Read and come.
Sure, sir.
Okay.